Good morning, everyone. This is a gate change announcement for the West flight E1393 to Doha. This flight will now departure from gate number 51 in the terminal range. Always kindly proceed to gate number 51 for boarding. Thank you. Now we wait for
Hello. Hello, Professor.
Yes, we can hear you. Hi.
Happy to see you.
Good to see you. Yeah. Doctor, you forgot to turn on your microphone. Your microphone is mute.
Oh.
No, not you. You're okay.
Oh,
You're
okay.
okay. Our
Thank
chairman,
you.
our chair lady, she's her microphone is you.
Professor Halida,
Okay.
can
Yeah,
you open your microphone?
she's on the airport. I think
Oh,
maybe.
I see.
Yeah.
That's
Hello.
fine.
Hello.
Maybe.
Hi. Yeah. Your chair, co-chair. Maybe our co-chair can respond to you.
Hello.
Okay.
Dr. Ozzy Saikan.
Oh, it's me.
Yeah, hi. So you'll be speaking
Hi.
first. Okay.
Okay.
So we have 1 more minute to go. Professor Sumro, you're muted.
Now?
Yes, we can hear you. Yes.
Okay.
Good. Okay.
So our first speaker is with us.
Okay, time is on.
Okay. Professor Dr. Nang, can I give my closing remarks after you also?
Okay.
If you say.
Okay. Shall
So,
I?
okay.
Good morning, everyone. If you are the best like 3.93, the dollar is now voting again 51. We will get in the one and get the back for the other statement for my members and we will get the score now. Is a passport and going to study for presentation and the gate and cut out. What are the rest with you here? Thank you.
Good morning. I welcome you our audience, speakers and co-chair. In the webinar organized by the APSC Cloud Forum of the Cardiovascular Diseases series. The topic of this webinar is sex-related differences in cardiovascular diseases, relook on the equitable care in women. But first of all, I will introduce myself. I'm Professor Cardiovascular Sumro, working as a cardiologist in Jardin University Hospital, coordinator of GORAT program for women in Pakistan, and as well as chairperson Scientific Council of Women with Heart Diseases, Pakistan Cardiac Society. The topic of, as we know that heart disease or CVD is #1 killer in women. And Sex-related differences exist in CVD physiology. Risk factors and aggravated by psychosocial factors, ischemic heart disease, acute coronary syndrome, heart failure, and arrhythmias. These disorders manifest with a different presentation, diagnosis, accuracy, and therapeutic outcomes comparing the men. Even comorbidities confer different effects, with the hypertension causing more heart failure or stroke in women, and also they can hypertension can give rise to the AF more in women than men. Diabetes causing high risk of these cardiovascular diseases in women. Pregnancy, delivery, gestational diabetes, and hyper and preeclampsia are the associated with the higher likelihood of the later cardiovascular diseases, even to the acute dissection, coronary dissection, MR, improved under the sex under the sex-related disorder risk factors. So improved understanding of the sex-related differences in cardiovascular diseases. We need continued effort in promoting and provision medicine in the cardiovascular diseases to get rid of the to control the mortality in increasing mortality in women. So now we will move to the our disclaimers. The content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the Asia Pacific Society of Cardiology. The view and opinion expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. I will hand over now the further proceeding to my other chair of this webinar, Dr. Ning I. Young. She is assistant professor and in the section of cardiology Department of Medicine, Chang Gung Memorial Hospital, Keelung, Taiwan. Over to you, Dr. Nang.
Thank you very much, Professor Sumro. Thank you for the opening and for the introduction. Hello to everyone. I'm very honored to be part of today's webinar on this really important topic, women cardiovascular disease. So we have 6 exciting talks ahead. And let me first introduce our very first speaker. This is Dr. Ganchimeg Ulisai Khan from Mongolia. She's a cardiologist in the cardiology department of the 3rd State Central Hospital in Ulaanbaatar, Mongolia. Now, her talk will be on sex differences in primary prevention of cardiovascular atherosclerosis, conventional versus sex-specific risk modifiers. So let us welcome Dr. Ulisai Khan.
Sorry. Sorry, could you listen? Can you listen? Hello?
Yes,
Yeah,
no
we
problem.
can hear you. No problem.
Okay, thank you very much. Dear Chairman, dear Professor and friends, I'm Dr. Kanchimik from Mongolia, and I'm really happy to join this webinar, and thank you very much for this great opportunity. Today, my topic is about sex differences in primary prevention of cardiovascular atherosclerosis, conventional as well as sex-specific risk modifiers. I'm sorry. So we all know cardiovascular disease is the leading cause of morbidity as well as mortality. By the 2019, almost 17.9 million people died from cardiovascular disease globally, which 85% were due to coronary heart disease and stroke. Both men and women, coronary heart disease is the largest contributor to the morbidity as well as mortality. There is a clinically important six differences in the prevalence of traditional risk factors. Also, there are specifically recognized risk factors unique to women and the development of the atherosclerosis. A systemic analysis of the global burden of disease study, which was included 404 countries, showed that common cause of mortality in both sexes were cardiovascular disease. And for women, the main risk factor attributable for mortality were high blood pressure, unhealthy diet, high fasting glucose, high BMI, and tobacco. Whereas for men, tobacco, high blood pressure, unhealthy diet, high fasting glucose, high body mass index, as well as high low density lipoprotein level, which indicates majority of the mortality associated factors were metabolic and modifiable risk factors. So this is the common traditional risk factors for atherosclerosis. And you can see traditional risk factors for atherosclerosis is similar between men and women, including modifiable risk factors such as obesity, dyslipidemia, diabetes, hypertension, inactivity, insufficient physical activity, and smoking. And non-modifiable risk factors include older age and family history. But there are also the prevalence of outcomes associated with individual risk factors differ in men and women. So we will, for example, age is one of the most powerful risk factors for developing cardiovascular disease. Due to cardioprotective effect of the estrogen, women tend to have delayed onset of coronary artery disease by 10 to 15 years. And by the after age of 55 years old, the risk of coronary artery disease becomes similar in between men and women. Compared to men, diabetic women have a greater burden of atherosclerotic cardiovascular disease risk, and diabetic control is often suboptimal in women compared to men. Also, prolonged smoking is more potent risk factor for women compared to men. Large-scale analysis results show that association between body mass index and coronary heart disease similar between men and women, but the risk of a stroke associated with BMI is slightly higher in men, and obesity is present at least 50% of the patients with hypertension, whereas more prevalent in abdominal obesity patients, which are prevalent in women. And more potent in women. Okay. Hypertension is a major health problem, both men and women. The overall prevalence is similar, higher, irrespective of the sex differences. But for healthy young women, blood pressure is lower than same age males, but experience increase in blood pressure from the third decade of life. Hypertension prevalence would be increased in women after age of 60 years. Study results suggest that postmenopausal women are more experienced non-dipping nighttime BP pattern. This pattern is associated with the risk of cardiovascular disease. Poor controlled blood pressure is also common in women. About dyslipidemia. Dyslipidemia is also common in both sexes. Low density lipoprotein has a greater influence in men than women, whereas high density lipoprotein is responsible for coronary heart disease in both young and old women. After 65 years old average, low density lipoprotein became higher in women compared to men. So for women, there is several specific atherosclerotic risk, cardiovascular risk factors, such as polycystic ovary syndrome, menopause, and pregnancy-induced adverse events such as gestational diabetes, preeclampsia, pregnancy-induced hypertension, low birth weight, and also other risk factors specifically associated with the woman is autoimmune disease, cardiotoxic chemotherapy, hormone replacement therapy, psychosocial stress, and low socioeconomic status. So we will introduce about the sex-specific risk factors. First, about the menopause. Age at the menopause is thought to be a marker for reproductive aging and general health. Relationship between menopause and cardiovascular disease is complex. Menopause increases cardiovascular risk due to psychological response to estrogen withdrawal, including changes in body fat distribution, reduced glucose intolerance, abnormal lipid, increase in blood pressure. There were study results showing that earlier and surgical menopause is actually more associated with the higher risk of cardiovascular disease risk. Preterm menopause, which is defined by menopause which is occurred before 40 years old, is considered to be a risk-enhancing parameter in the recent guidelines. Pregnancy is a stress test for women, and these adverse pregnancy outcomes can be used to identify women who are at the increased risk of atherosclerotic cardiovascular disease, even in those for whom the condition resolved after delivery. Adverse pregnancy outcome appear to be 10 to 20% of all pregnancies and associated with the 2 to 4-fold increased risk of future cardiovascular disease. For example, preeclampsia was included in recent American College Cardiology Prevention and Dyslipidemia guideline, as well as ESC prevention guideline as a risk enhancer. Preeclampsia could induce 3 to 6-fold of increased risk in subsequent hypertension, as well as 2-fold increase in ischemic heart disease and stroke. Gestational diabetes is also a common cause for the coronary heart disease, and it is 2.4 to 20-fold increased risk for type 2 diabetes, and 2-fold increase in hypertension, 2-fold increase in ischemic heart disease, as well as stroke. And miscarriage stillbirth is associated with 1 to 45 to 2 times increase in cardiovascular risk, including myocardial infarction, cerebral infarction, and renovascular hypertension. So it is important to recognize adverse pregnancy-associated outcomes when cardiovascular risk is evaluated in women. Furthermore, these risk factors often do not translate to women as a predictor of future risk for coronary heart disease and are often not assessed when standard cardiovascular risk assessment tools were used. About psychosocial psychological disturbances. Emotional stress and psychological disturbance are many. There were increased risk for women, increased risk for cardiovascular disease in women. There were many clinical observations, and they have demonstrated linkage between acute and chronic emotional stress and psychological disturbances and the increased risk of cardiovascular disease. Psychosocial stress tends to be more important risk factor for cardiometabolic disease in women than in men, possibly because women in general have higher exposure to psychosocial stress compared to men, and also women may be more vulnerable to the effects of such exposure. There were studies that depression is about twofold more common in women than men. Whenever the woman depressed, the cardiovascular risk doubles over the years. And studies in USA demonstrated that post-traumatic stress disorder affects more women compared to men. At the same time, those with history of trauma but no post-traumatic stress disorder symptoms also showed an elevated cardiovascular disease. This is the concepts of recently published international guidelines for the sex-specific prevention of cardiovascular disease. So as for 2021 EAC prevention guideline, they have included sex-specific clinical conditions and clinical management strategies, also specific health concerns related to gender was acknowledged. And 2019 American prevention guideline was added risk enhancing factors, a concept that may particularly advantage for women. And 2020 American College Cardiology Cardiovascular Women Committee actually published a statement a recommendation for primary prevention of cardiovascular disease in women. So this is the risk enhancing factors which was included in the American primary prevention guideline. So advocated in this listing is the consideration of features unique to predominant in women. These include pregnancy-associated condition such as history of preeclampsia, preterm delivery, small gestational age infants, chronic inflammatory disease, including rheumatoid arthritis and systemic lupus. And if it's measured, if measured, whether there is a persistently elevated inflammatory markers, a history of premature menopause is also included in this risk enhancing factors. These are the major international, this is the risk enhancing factors. And these are the major international prevention guidelines recommended for atherosclerotic cardiovascular disease risk estimate calculators. All major international guidelines recommend to screen for traditional cardiovascular risk factors and apply the risk assessment. Sometimes one risk assessment tool could underestimate or overestimate a person's CVD risk. So clinicians could use other alternative risk prediction tools, even though slight differences do exist across these different organizational guidelines. Overall, they are very similar. These are the most common used risk scores, including Framingham risk score, pooled cohort equation score, which is used in European prevention guideline, and Q-risk tree, which is used in UK. So despite these risk scores calculated separately for men and women, other sex-specific unique risk factors such as pregnancy-associated condition, chronic inflammatory disease, and history of premature menopause still did not include in those assessment questionnaire. Also, majority of the risk scores are recommended in adults from age of 40 years old, whereas women in active reproductive, which is age 22 to 39 years, need to pregnancy-associated risk factors in order to identify the younger woman at increased risk. And we will move on to the management. The InterHeart study identified potentially modifiable risk factors account for 96% of the population attributable risk of myocardial infarction in men and women. So the management of traditional risk factor is most important part for the primary prevention for both men and women. So we will start from the non-pharmacological treatment. Its lifestyle change would include healthy diet, smoking cessation, as well as exercise and physical activities. It is recommended that to adopt Mediterranean and DASH diet and smoking cessation irrespective of the sex. And physical activity is also recommended for the healthy adult, at least 150 minutes weekly or moderate intensity, or 75 minutes for vigorous intensity aerobic physical activity. InterHeart study, the protective effect of exercise were greater for women than in men. There was showed that women has a much more protective effect after physical activity. This is the healthy diet. All adults, irrespective of sex, should consume healthy diet. And unhealthy diet quality is strongly associated with elevated risk of cardiovascular disease. Evidence-based dietary pattern guidance to promote cardiometabolic health indicates the following. It emphasized to more take fruits and vegetables, nuts and whole grains, and eat fish, preferably fatty fish, and minimize the intake of the trans fats, red meats, processed foods, and sweetened beverages. And it's recommended to restrict alcohol consumption to a maximum of 100 grams per week. About lipid management, there are no specific recommendations regarding the treatment of treatment as well as target. All people with dyslipidemia or the high risk of dyslipidemia, the healthy lifestyle intervention is needed. Statin therapy is the first line drug treatment. And there was a similar beneficial effect was seen both men and women. And given the lack of the statin safety data in pregnant women or women who are planning to becoming pregnant, need to be truly consult with the clinician and maybe avoid to use statin. And statin is now, according to the American Primary Prevention Guideline, statin is recommended for a specific group of people, which includes for primary prevention in adults age of 40 to 75 years old at high risk, intermediate risk or borderline risk based on the risk in hazards, and familial hypercholesterolemia, and also patients with diabetes. They need to have statin therapy. And women are, compared to men, more at risk of developing statin-induced muscle symptom. So in those cases, we could offer other lipid-lowering agents, but unfortunately, the ezetimibe as well as PCSK9 are haven't had the primary prevention setting. These drugs' primary prevention setting still not well understood. But from the secondary prevention part, these drugs may be relatively safe and could be efficient for both in men and women. For diabetes, there is also no sex-specific recommendation regarding the treatment of the target. All diabetic patients for primary prevention, healthy lifestyle changes is recommended. Target blood HbA1c is less than 7%. Metformin is the first-line therapy along with lifestyle changes to improve glycemic control and reduce cardiovascular risk. Glucagon-like peptide-1 receptor agonists and SGLT2 inhibitors, the new glucose-lowering drugs. They are both appeared safe regardless of sex and do not lead weight gain. And from the sex-wise, with GLP-1 receptor agonist, men have a better glycemic control, whereas women has a more weight loss. For adults with hypertension, there is a newly published scientific statement regarding sex differences in arterial hypertension, but no sex-specific recommendation. Target blood pressure for both men and women is less than 130/80 millimeter mercury. And all patients with hypertension, healthy lifestyle changes is recommended. Salt restriction is beneficial after menopause, but no specific recommendation based on sex. Limit and structured aerobic exercise therapy could reduce blood pressure in male compared to female, and males treated with hypertension achieve better control than female. And females experience more antihypertensive drug-related adverse effect, except for mineralocorticoid receptor antagonist. About aspirin treatment for primary prevention, again, no sex-specific recommendation, but low-dose aspirin may be considered among selected adults at higher atherosclerotic cardiovascular disease risk, but not at increased bleeding risk. Those people include current smokers, strong familial history of premature atherosclerotic cardiovascular disease, people with suboptimal control lipids, and those with subclinical atherosclerosis. It should not be routinely used for primary prevention among adults older than age 70 years old. Then we will move on to the prevention management of women-specific risk factors. So according to the American Cardiovascular Disease in Women Committee recommendation, women who had experienced adverse pregnancy conditions require further cardiovascular risk screening within 3 months of postpartum based on medical therapy, physical examination, and laboratory testing results. The American College of Obstetrician and Gynecologists recommendation called this period the fourth trimester to expand the focus beyond the traditional single postpartum visit. Longer duration postpartum care, such as screening for the development of cardiovascular disease risk factors and provide patient education about cardiovascular disease risk prevention rather than simply offering a single postpartum visit would improve long-term risk reduction for patients. For example, preventing future cardiovascular disease, a woman who had preeclampsia or gestational hypertension, lifestyle modification including smoking cessation, dietary counseling, physical activity, weight management, BP control, and constant follow-up is needed. And the primary prevention committee strongly encourage breastfeeding because breastfeeding during the first year postpartum may play a very important role in reducing future risk of cardiovascular disease in women. lactation could reduce fasting blood glucose, triglyceride, insulin-resistant blood pressure, as well as it could increase high density lipoprotein level. And in the end, it could decrease the risk of early atherosclerosis. About menopause, currently in guidelines, menopausal hormonal replacement therapy is not recommended. For young patients who are suffering from postmenopausal vasomotor symptoms, careful assessment of individual and familial risk of venous thromboembolism is needed. Why? Because the large cohort of study, Women's Health Initiative randomized controlled trial results showed that overall health risk exceeded the benefits from using combined hormonal replacement therapy in healthy postmenopausal women. So now in the guidelines do not recommend the hormonal replacement therapy. I'm sorry, hormonal replacement therapy. About psychosocial risk factor management, early recognition, management of psychosocial stressor should be useful in promoting healthy lifestyle, improve quality of life, and yet still we don't have enough, we don't have guideline how to manage psychosocial risk in order to decrease cardiovascular disease. In conclusion, men and women has different manifestation of atherosclerotic cardiovascular disease, and there are 6 differences in their responses to risk factors and treatment. Also, there are unique sex-specified risk factors that increases future cardiovascular risks in women, yet in measure prevention guidelines do not include sex-specific recommendation to risk assessment as well as in the management. So further deeper understanding of the sex differences and implement risk management strategies is crucial. Thank you very much.
Okay. Thank you very much, Dr. Ozi Sakan, for this very comprehensive review of sex-specific risk factors for atherosclerosis. I think because of time, maybe, can I ask you a quick question? Yeah.
Sure.
Yeah. I think
can I ask one question?
Oh yeah, sure.
Recent article from the India shows that the vascular inflammation in the elderly women is a risk factor. Interleukin 6 may be the responsible for that. Have you any study in the apart from the southeast countries in Asia for that purpose in developed countries of the Asia Pacific? Because Southeast Asia or elderly women, especially in India, is having vascular inflammation above the age of 70 years when estrogen, there is lack of estrogen and the LDL-C is increased usually. Apart from that, interleukin 6 is responsible for, they said that interleukin 6 is responsible for the vascular inflammation. Number 2, they said that the abdominal obesity and fat around the liver and the cardiac fat and fat in the abdomen is also a reason for initiating the inflammation. So that may be the great risk for the women of the South Asian countries. But I don't know about the developed countries of the Asia.
Thank you very much, Halida. Unfortunately, in Mongolia, we also haven't had any specific risk sex differentiated coronary or atherosclerotic risk factor associated studies. So I'm not sure about it. Yeah, currently.
Okay.
Okay.
make a quick comment, please? It was a very comprehensive talk. Can you hear me? This is Professor Nusrat from Islamabad, but I would just point out two, disparities. She mentioned the protective role of estrogens in younger women. I'm sorry, that used to be the concept some 2 decades ago, but now we are seeing younger and younger women falling victim to IHT, and that is why the American Heart Association came up with their signature program, Go Red for Women. And number 2, she mentioned hemoglobin A1C should be less than 7, but these days internationally accepted figure is less than 6, ideally between 5.5 to 6. Thank you.
Okay, thank you very much.
Thank you very much for the update. Okay, I think because of time, I thank you very much for this wonderful talk. We'll need to move on to the second speaker. Okay. Okay, let me introduce the second speaker. This is Dr. Fatima Kuratullain from Pakistan, who is an assistant professor in cardiology at Punjab Institute of Cardiology in Lahore, Pakistan. And the topic of the talk is sex differences in clinical care and consequences of hypertension, obesity, and diabetes. Okay, let us welcome. Thank you.
Hello. Hello, can you listen me?
Yes, we can. Please
Yes.
go ahead.
Hello, everyone. I'm Dr. Fatima Kuratullain from Pakistan, and today my talk. I'm very glad that I have got this opportunity to share my views with you. And today my topic of talk is sex differences in clinical care and consequences of hypertension, obesity, and diabetes. To start with, fear your Lord who initiated your creation from a single soul, then from it created its mate, and from these two spread countless of men and women. And so God created men and women equally, and they should be treated in the society in the same manner. So the hypertension, obesity, and diabetes are considered the risk factors for many of the cardiovascular diseases like coronary artery disease, stroke, and many other pathologic conditions. And all these diseases have some modifiable and non-modifiable risk factors, and sex is considered is one of the non-modifiable risk factors. What is meant by sex of a person and how it differs from gender? This is some concept that most of us may be unaware of, that we invariably use the both terms sex and gender simultaneously. But according to Canadian Institute of Health Research in 2020, sex refers to a set of biological attributes that includes chromosomes, gene expression, hormone levels and function, and reproductive and sexual anatomy. Whereas gender refers to a society constructed roles, behaviors, expressions, and identities. So any sex can play a role in any form of gender. Like some of the females may be playing socially, they are behaving like males. There is one table that shows that there is some intersectional influence of sex and gender on disease risk, treatment, and complications across the whole lifespan, starting from preconception to the adulthood, like pregnancy, post-menopausal time. The gender variables and biological variables, they are like interacting at every stage of life and contributing in the causation of disease in different manners. This is one more flowchart that is showing that there are some traditional risk factors like hypertension, smoking, obesity, diabetes, and dyslipidemia, and some non-traditional risk factors like physical activity, depression, sex-specific risk factors like hypertension, pregnancy disorders, gestational diabetes, and hormonal-related risk factors, and some novel risk factors like inflammation. And all of these traditional and non-traditional risk factors are interacting with biological sex and gender variables and creating an imbalance in the cause of disease in the different sexes. And we need to understand this intersectionality between sex and gender that ultimately result in different disease outcomes and different disease scores. We will discuss in some future and further slides. So how does sex matter as a risk factor? And one of the study in 2001 Institute of Medical Reports says that exploring the biological contributes to human health confirmed that significant differences between sexes affect prevalence, incidence, and severity over a broad range of diseases. But one of the issues is that women were excluded from most of the clinical trials. As a result, prevention, diagnosis, and treatment of severe chronic diseases such as cardiovascular disease continue to be based primarily on the findings in men, and sex-specific clinical guidelines are mostly lacking in most part of the world. This is the one table that shows the major cause of death globally in mainly in women. Like in globally, coronary heart disease and stroke are two most leading causes of the death. But in United States, it's coronary artery disease and Alzheimer's. And in high-income countries, it's same like US, it's coronary artery disease and Alzheimer's. But in low-income countries, like India, it's still coronary heart disease remains the leading cause of death in women, but the second most common cause is COPD. And now we will discuss some sex differences in hypertension. What is hypertension? According to AHPCC 2007 hypertension guidelines, patient having blood pressure, office blood pressure of more than 130/80 in two different occasions is said to be hypertensive. And the prevalence of hypertension according to WHO is 1 in 4 in men and 1 in 5 in women in 2015. And that is higher in men than women over the age of 60 years. And Nahani's data demonstrate that the lower prevalence of hypertension in younger women that have different reasons, like the prevalence in hypertension in the United States decreased in women overall between 1999 to 2018, whereas overall it has increased in men. And combined impact of hypertension and lower income on cardiovascular outcome is more in male population in one study in China and India than in female population. And there's also a small study from East Africa that indicates that in East Africa, the incidence of hypertension in women is twice as compared to men. So these were some studies that were taken from the different parts of the world. And some of the contributing factors that are the cause of the sex differences in blood pressure are mediated by factors like renin-angiotensin aldosterone system that behaves somewhat differently in the two sexes, and bradykinin, nitroxide, and predominantly it is sex hormone mediated and specific impacts of estrogen, vasculature, and sympathetic nervous system. These differences begin in adolescence when males demonstrate higher BP than females, and extend into later life where more males have hypertension until the 6th decade, after which it becomes more prevalent in women. Here you can see in the table that premenopausal women typically have lower blood pressure than men, and with advancing age and in postmenopausal time, like at the age of 60 to 69 years, it becomes comparable in both men and women. Initially, it's higher in men, and even after the age of 70, it's a bit higher in women, hypertension as compared to men. Then there's impact of sex and complications of hypertension. Different studies has shown that hypertension may be a more important risk factor for acute coronary syndrome and heart failure with preserved ejection fraction in women as compared to men. And conditions associated with pregnancy, such as preeclampsia, are associated with a short-term increased risk of postpartum hypertension and a long-term increase of cardiovascular disease. And cardiovascular disease increased beginning at lower threshold systolic blood pressure for women than men. This table is demonstration of that you can see at systolic blood pressure at much lower levels of systolic blood pressure of like 110 to 119 millimeters of mercury. The women are having increased risk of cardiovascular disease and heart failure. And but as compared to men who have this increased risk at the systolic blood pressure 150 to 159. Even in case of stroke, females have this increased risk even at systolic BP of 120 to 129, whereas men have these increased risk after the blood pressures of 150 millimeters of mercury. And CKD, which is one of the most serious sequelae of hypertension, is found more commonly in men as compared to women. And there was a study that was conducted in India that showed increased prevalence of CKD in men than women. These were some of the data from Asia. So there is, depending on these studies, we have seen that there is some difference between prevalence of hypertension in men and women and the age at which it's more prevalent in women. And this must have some basic factors behind that. And some of them are like pharmacokinetics. Also, there is a difference in response of medication antihypertensive medication in men and women. And the contributing factors are maybe pharmacokinetics and pharmacodynamics are somewhat different in both sexes. Like male and females have different GI acid composition. They have different volume of distribution and somewhat differences in hepatic metabolism as well that contribute to these factors. There were also pregnancy-related differences, like pregnancy-related concerns that you can use some antihypertensive drugs like ACE and ARBs. They have teratogenic effects and they cannot be used in pregnancy and lactation. So they also causes preference of some drugs in pregnancy that can't be used in female, but this was not present in case of male. And there are also some biological factors like salt sensitivity and renin-angiotensin system is also responding differently in the both sexes, female being more salt sensitive. So one of the analyses of Stockholm regional healthcare data noted that women were treated with different antihypertensive medications, and they were dispensed fewer medications for women as compared to men. They're mostly treated with the calcium channel blockers and beta blockers, while it was found that that generally male are mostly commonly treated with ACE and ARBs preferably. Less presentation, and this is just one of the cause that we can't find the actual response, and is that women are less included in the trials. Even in one of the major landmark trials, Spain trial, included only 30% of the participants were women. So, but some recently increased awareness in countries like China and other South Asian countries. Increased awareness of young women have led to better hypertensive control in young women compared to young men. Now we will move to obesity. What is obesity? Obesity is defined as abnormal or excessive fat accumulation that presents a risk to health. A body mass index over 25 is considered overweight, and over 30 is obese. Obesity has become one of the epidemic in the world. It is an epidemiological predictor of premature mortality. According to WHO, over 4 million people dying each year as a result of being overweight or obese. The prevalence has increased, like the overweight obese children and adolescents aged 5 to 19 years increased more than fourfold, from 4 to 18% globally. And the prevalence of obesity in the United States increased from 30.5% to 40% from 1999 to 2018. And also the severe obesity has also been increased. And the latest NAHANI's data reported for the first time a similar prevalence of obesity in men and women, that is 43% in men and 41.9% in women. This shows the prevalence of obesity among age 20 to 20 years and above, and there is no gender sex-based major difference in prevalence of obesity. In one study, the non-Hispanic Black women are more obese than non-Hispanic Black men, and the non-Hispanic Asian descent, they have lower prevalence of obesity as compared to Hispanics, and but there was no specific difference on the basis of sex. The severe obesity, the prevalence severe obesity is more than 9.2%, and it is more common in a woman between the age of 40 and 59 years than men. Main manifestations of obesity, like obesity is mostly central or visceral, that is apple-shaped, we call it apple-shaped obesity in men, versus it's a hip or subcutaneous spatial distribution in women. And the visceral adipose deposits are classically less insulin sensitive, and they're associated with increased cardiometabolic risk. That's why central obesity in men is more predisposed to developing cardiovascular disease as compared to women. And a global analysis of 10 million people from 239 studies originating from Asia, Australia, New Zealand, Europe, and North America evaluated the impact of sex and BMI on mortality. That showed that men had a greater hazard ratio for mortality with increasing BMI. This is a graphical representation of that, and you can see with the increased BMI, males have increased hazard ratio. There's if we discuss the sex differences for the treatment of obesity, there are no specific differences have been studied on, but in most of the studies, as female are more conscious about their weight and their physique, so that's why maybe one of the reasons that most of the studies on obesity have done on the female. In contrast to other cardiovascular outcomes, most participants in weight loss trials and lifestyle interventions were women. And the new agents that are mostly being used nowadays, the first line therapy for the obesity is obviously lifestyle modification, decrease diet modification, physical activity, and behavioral changes. And even after that, and the cutoff for the treatment is like over 27, BMI of 27 with comorbidities, and if the patient doesn't have comorbidities, then we will treat at the BMI of 30. And if the BMI is more than 30, then we can, the patient not responding to this non-pharmacological treatments, then we can go for some pharmacological treatment that include orlistat and like phentermine or topiramate combination, or bupropion or naltrexone. But these are some of the treatment options that have been used. And after that, if the patient doesn't respond to that, then we can go for bariatric surgery. Some new agent obesity are being studied in both sexes widely, and some pre-specified analysis of the full suite of step 1 trial for semaglutide may offer the opportunity for well-powered analysis to define sex differences in medication tolerance, weight loss, and cardiovascular benefit, but they still need to be studied. Women currently undergo bariatric surgery more commonly than men. Approximately 80% of bariatric surgery patients are women and 20% are men. Now we'll move to sex differences in diabetes mellitus. The diagnostic criteria for by the American Diabetic Association is the fasting blood plasma glucose level of 126 milligram per deciliter or higher, or a 2-hour plasma glucose level of 200 milligram per deciliter or higher during a 75-gram oral glucose tolerance test, or a random plasma glucose of 200 milligram per deciliter or higher in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis. And a HbA1c level of 6.5 or higher is considered to be diabetic. A total of 34.1 million people live with diabetes in the United States. 13% of men and 11% of women are affected. So there's some demographic data that is showing the prevalence of diabetes in men and women. There is no major gender sex-based difference. And then some difference according to ethnicity and education levels. This is one study that we have taken from Pakistan that shows the age and sex-based differences in diabetes prevalence in urban and rural areas. And there is in urban and rural areas, there's no major difference in the prevalence, except it's slightly more prevalent in the men in the earlier age, and but in the later age, it's equally prevalent in the both sexes. But in the later age, if we see in women above the age of 40 years, it's a bit more prevalent, especially in the urban population. This is one study showing the prevalence of diabetes in India, which shows that diabetes is 11.8% people aged above 50 years, according to a government survey, and highest prevalence of diabetes was observed in 70-79 years age group, that was 13.2%. But in the remaining age group, there is no major difference among the different genders. The sex differences in the diabetes is like prevalence in Hispanic population has more than non-Hispanic Black, and there even more, and then the non-Hispanic Asian people. The effects of sex on diabetes risk were not robustly evaluated in the Centers for Diabetic Control and Prevention. In one of the studies by Nihanis and WHO, youth onset type 2 diabetes is rapidly increasing with that 2:1 female predominance. And there was one study in China that showed that male youth are more likely to have pre-diabetes than female youth. And gestational diabetes was highest in Hispanic population. Diabetes-related hospitalizations and mortality are greater for men than women if we study the complication related to diabetes. In US, there's a consistent relationship between increase in obesity with increased incidence of diabetes that is highest in non-Hispanic white women. And girls have, this shows that because girls are relatively have lower physical activity and more sedentary lifestyle than boys, and that increase obesity and decrease physical activity that ultimately increase the prevalence of diabetes. This is a graphical representation that's showing with the increased age, the increased prevalence of diabetes in both men and women, in a slightly higher in men. This is the BMI-based prevalence in both sexes, in men and women. And that shows with increased BMI, there's increased risk of developing diabetes. The premenopausal women without diabetes have fewer heart attacks than men. That is one of the contributions for physiological differences, including the impact of sex hormones, differences in cardiovascular risk factors, and differences between sexes in the diagnosis and treatment of diabetes and cardiovascular disease. A striking difference is the loss of cardioprotection in premenopausal women with diabetes relative to age-similar women without diabetes. Even short diabetes exposure, such as gestational diabetes, is a specific risk factor for cardiovascular disease. Considering the treatment option, there is no guidelines that show that the sex-based differences in the treatment of diabetes in men and women, but it has been seen that women with type 2 diabetes are less aggressively treated. And there are some studies that show the sex difference in effect of diabetes and cardiovascular disease and medication effect, that men had greater response to sulfonylureas and women responded better to thiazolidinediones. But that is not part of guidelines. These are some studies that have showed that. And lower glucose lowering drugs such as glucagon, like peptide 1 receptor agonists, were associated with a lower risk of cardiovascular events than sulfonylureas, and the effects were stronger in women and men. But considering the treatment, the first line therapy still remains the lifestyle modification and along with the addition of metformin. And then if we need the further decrease the glycemic level, then we can, if the patient has higher atherosclerotic disease risk, cardiovascular disease, then the first line treatment remains SGLT1 and GLP-1 analogs to prevent the hypoglycemia. And if the patients further, we need to up-titrate the treatment. We will first up-titrate these drugs and then we can move to insulin. But in the patient population who don't have atherosclerotic cardiovascular disease risk, we can start with any of the treatment options after metformin, like we can add with SGLT1, we can add with GLP, we can add with sulfonylureas or thiazolidinediones, depending upon the requirements for weight loss or socioeconomic preference of the patients. There is one study that showed that women with diabetes and cardiovascular disease had poor control of cardiovascular disease risk factors, including lipids, blood pressure, and low density lipoprotein cholesterol, as well as HbA1c as compared to men. And these findings identify the need for prospectively designed studies to investigate sex differences in pharmacological, interventional, and behavioral treatments for diabetes. Now, sex differences in clinical care for hypertension, obesity, and diabetes, that is a main call to action. That despite the significant sex differences revealed by the literature in hypertension, obesity, and diabetes, only recently has the idea of sex-specific clinical cardiovascular care has emerged in the recent ESC guideline, that they have said that it should be studied separately, but still there is no specific guidelines available. No specific sex-specific recommendation for the management of hypertension, obesity, and diabetes have been drafted, largely because of lack of prospective evidence-based support for such guidance. These are the different guidelines that we use for the treatment of hypertension, obesity, and diabetes. And as we have discussed earlier, and my other colleagues have also discussed the treatment options with you people, but as we can see in all these guidelines, there's no screening of targets that differs by sex or gender. Only some pregnancy-related disorders, peripartum, postpartum factors have been studied, have been included in the guidelines, but no major biological risk factors of sex-related have been discussed with these guidelines. So what are the areas that we should need to address is the lack of sex-specific care recommendations and inadequate inclusion of women in clinical trials. And that's why increasing the sex differences observed in hypertension, obesity, and diabetes are leading to evidence-based reports of sex differences and outcomes. This is one of the proposed model to investigate the critical role of gender and identity and sex in the planning, analysis, and conduct of clinical trial. Like when we're planning to start a study prospectively, we should plan we should define the term sex and gender, and define the role of sex and gender in your research question, and then design your research accordingly with inclusion exclusion criteria, including these subgroups as stratified randomization. And then we should recruit and adhere according to this. And data collection analysis should be done in these considering these points in your mind, and that should be disseminated for the formation of the new guidelines that should be based on this sex differences. And this is one of the other table that shows that how the men and women differs in pathogenesis, epidemiology, treatment, and outcomes, and its gender-based risk and infrastructure to impact these risk factors. So the research is needed in the form of prospective randomized control trials, secondary control, randomized control analysis, real-world formal gender assessment to form a pre-specified sex gender power analysis to make evidence-based sex gender specific clinical guidelines. So future directions and recommendation that understand and incorporate sex differences in studies, evaluate and incorporate gender constructs, understand the biological basis for the influence of sex, and to bring these findings to establishing sex-specific clinical guidelines. And to conclude my today's talk, that understanding the influence of sex to inform optimal clinical guidance and improve the health of men and women will require comprehensive analysis of available data dedicated to these issues and thoughtful decision of further prospective studies to formally address sex and gender. The prophet said, there is no disease that God Almighty has created, except that he also has created treatment. Thank you.
Great. Thank you very much, Professor Kuratulan, for this very clear and comprehensive review of differences in hypertension, diabetes, and obesity, and in men and women in particular. There seems to be a lot of differences, and again, a lot of questions arise as to why we don't have sex-specific recommendations, because obviously men and women are really very different. Now, I don't know if any of the other participants have any questions. Okay. If not, thank you very much for this wonderful talk. Yes, great. And I think if we can move on to the third talk. Okay. The third talk will be given by Dr. Chawan Lim from Malaysia. She's a cardiologist and electrophysiologist at Pantai Hospital in Kuala Lumpur, Malaysia. The title is Sex Differences in Acute Coronary Syndrome, Presentation, Manifestation, and Therapeutic Outcomes. Now, let us welcome Dr. Lim.
Thank you very much, Professor Young, for your kind introduction. Hello to panel speaker. I'd just like to thank everyone today for including me in this today's webinar. I'm really honored to be sitting on the same platform as the esteemed speakers here today. So my talk today is on sex differences in ACS, looking at presentation, manifestation, therapeutic outcome. So the outline of my talk today is looking at CVD in general in women, their presentation and manifestation. How different do we differ in terms of presentation? I'm going to share with you as well on Malaysia data on our ACS registry and also therapeutic outcome. And finally, addressing the gaps in our treatment, gender treatment. Now, cardiovascular disease remains the most common cause of death in women globally. And in Europe alone, we know it's responsible for close to 50% of death in women, a little bit less in men, 40% in men, and 1 out of 3 women will die of heart disease. So really the bigger concern should really be cardiovascular disease. Now, over the past 40 years, we've seen significant progress and improvement in terms of mortality, reduction in CAD or ACS in our younger men. But alarmingly, we are also seeing increasing mortality rates in ACS in younger women, especially so in those under 55. Now, if you look at total death in USA, this is data taken from 2014. There was a total death of slightly more than 1.2 million deaths. And out of this, you can see that close to 400,000 is attributed to cardiovascular disease alone. And in the USA, in every 79 seconds, there's a woman dying from cardiovascular disease. But yet we are still made to believe that there are other more womanly issues. And quoting renowned Dr. Nanette Wenger, who's a pioneer in championing cardiovascular health in women, she's once mentioned that the medical community itself actually view women almost with a bikini approach, meaning that we focus primarily and essentially at the breast and reproductive system, but almost ignoring the fact that the rest of the woman is also part of women's health. So this is very evident as well and very clearly seen here with the underrepresentation of women in most cardiovascular trials. If you look at this chart, you can see that the percentage of women enrolled in randomized control trial, when compared to disease prevalence or mortality rate, there is a significant gap there. And we know that the gap in the knowledge inevitably actually adversely impact our women's heart health. Health disparity in women presenting with ACS have been receiving growing attention in the recent years. However, we know that clinical outcomes from ACS are still far worse for women, and women continue to experience higher patient and system delay. And we know that generally across registries globally, they also receive less aggressive invasive therapy and also less evidence-based pharmacotherapies. Now, if we look at presentation and manifestation, do we really present so dissimilar from the male gender? Well, we actually present pretty similar between men and women when it comes to ACS. Over 80 to 90% of both gender actually report chest pain during presentation. Although women do report more atypical symptoms, 1/3 of women in registry report atypical symptoms and also additional non-cardiac symptoms. And in addition to that, among those who present without chest pain, female sex is more common. And again, as we know, women are more likely to have worse health status at the time of ACS. This partially can be explained by the fact of health-seeking behavior, where women take longer to present for medical attention from the onset of symptom. And also they are less likely to have diagnostic testing such as ECG and troponins. And due to atypical symptoms as well, there are higher likelihood of misdiagnosis and under-treatment. Now we know that in ACS cohort, women are more likely to experience spontaneous coronary artery dissection or Takotsubo. Takotsubo is more prevalent in the postmenopausal woman, whereas for SCAD, you see them more prevalent in a younger woman presenting with ACS. As mentioned earlier on by our earlier speakers, that menopausal phase, early menopause and premature menopause too contributes to increased risk of CVD. And estrogen decline and withdrawal during menopause causes changes in terms of alteration of body fat distribution. It causes endothelial dysfunction, vascular inflammation, and increase in sympathetic tone, as well as insulin resistance, which contributes to CV risk in women. Again, if we look at trials or HRT, we know that over the years now, this has been phased out. Randomized control trials now largely fail to show any CV benefit of HRT in the women. In fact, there's increased event rate in post-menopausal women. So the use of HRT for primary and secondary prevention of CVD now is generally not recommended. And the relook at the reanalysis of the Women's Health Initiative, however, suggests that HRT in specific cohort of patients, if given in a timely manner in early menopausal period, may be beneficial again in a very, very specific cohort of women with no prior history of CVD. Again, as mentioned earlier, women, this is specific to gender with pregnancy-related complications. Now, pregnancy is often quoted as providing a glimpse into a woman's future health status because it actually predicts a future CV risk. So pregnancy-related complications such as preeclampsia, gestational hypertension, diabetes increases a woman's risk for future CVD. Take example, gestational diabetes itself is shown to increase CAD risk by 2 to 3-fold, even after 25 years of delivery. So taking the consideration of pregnancy-related complication and adding this to our traditional risk models, perhaps we are then able to improve our risk prediction of CVD in women. I'm just gonna talk you through this very busy slide of a pictogram that summarizes pathophysiology, presentation, outcomes of ACS in women and men. Now, if we look at women, how different do we present? On top of traditional risk factors that are stronger predictors in men, we know that women too have non-traditional risk factors, and these are usually related to psychosocial status, social economic status, depression, mental stress. Now, we know that women that present with ACS across registries globally, as well as in developing countries, you see more comorbidities in this group of cohort of women. There's more hypertension with women with ACS, and there's also higher, more frequent CKD, heart failure as well. Women that smoke have a stronger risk predictor than men, and there's also higher prevalence of smoking and obesity in young women with ACS. Now, specifically to gender, now there is also additional risk contributing to risk factors of ACS would be pregnancy-related risk, as mentioned earlier on, and female-specific risk factors such as PCOS, rheumatoid arthritis, SLE, and use of hormonal contraceptives. Again, alluding to symptoms, typically 80% present very similarly. However, we do have additional atypical symptoms and also non-cardiac symptoms such as abdominal discomfort, nausea, vomiting, breathlessness, and anxiety. And this continue to pose as a dilemma or confusion or leading to misdiagnosis. And also it's been reported that women more often report emotional stress prior than ACS. So the triggering factor seem to be related to stress as compared to men having more triggering factor as physical exertional related. Now, I'm just going to share with you our local data to see how different are we compared to global registry and whether there's any significant gender differences. The data that I'm sharing now is our local registry from the NCBD ACS registry. This is an ongoing multi-center observational prospective registry of our patients presenting with ACS, so which includes STEMI, non-STEMI, and unstable angina. So the registry started in 2006, which really designed to evaluate clinical presentation management and our outcomes in those with ACS, and patients recruited were those above 18 had clinical features consistent with ACS with ECG and biomarkers. The data we'll be presenting today are based on the data collected from January 2012 to December 2016. Now, these were data taken from hospitals nationwide, including tertiary hospitals as well as secondary hospitals and academic teaching hospitals. A total of 36,000 patients were enrolled. 35,000 were included in the analysis. So up to 50% were a STEMI cohort, another quarter each for non-STEMI and unstable angina. Now, if you look at the breakdown in terms of gender and presentation of ACS by gender, you can see a startling difference in terms of proportion of men to women. There's an overrepresentation on men, with close to 80% of men in our ACS cohort, and women only make up merely 20% of it. Now, we probably would rather say this is an underrepresentation of women. So we have a ratio of 4:1 men to women ratio in our cohort, when in fact, Malaysia population estimation for the year 2019 has a ratio of men to women of 107:100. So this glaring underrepresentation of women in our cohort is partially explained by the fact that Perhaps women present later for ACS, and also there is also misdiagnosis due to atypical symptoms, as well as health-seeking behavior due to cultural beliefs and differences. Looking at baseline characteristics and risk factors, across the cohort, you can see that across all three stratums, STEMI, non-STEMI, and unstable angina, you can see that our women are significantly older than men, on average 6 to 7 years older than men in the ACS cohort. And this echoes registries elsewhere as well. And we know that women now present later than men, lagging behind 7 to 10 years in terms of development of ischemic heart disease. And you can see that in our local registry as well. Now, our women in the ACS cohort had more diabetes, hypertension, dyslipidemia. They also had more previous heart failure and kidney failure. Now, when compared to men, there were less women with previous MI, and they were less likely to be smoker or ex-smoker. So to summarize in terms of baseline characteristic and risk factors of our women in the ACS cohort, they were significantly older. They were more they were more likely to have diabetes, other comorbidities such as diabetes, hypertension, dyslipidemia, and heart failure. They were less likely to be smoker and less likely to have history of previous myocardial infarction. Now, this is very similar to registries from elsewhere and also from the Western countries. Therapeutic outcome. So let's see how well do we do in our registry. Now, if you look at our in-hospital medication or pharmacotherapy-wise, more than 90% of both gender receive aspirin or other form of antiplatelet, and more than 88% of them receive dual antiplatelets. However, the fewer women were actually prescribed aspirin in the STEMI or unstable angina cohorts. Now, across the ACS stratum, more than 50% were prescribed ACE inhibitors, and more than 40% were prescribed beta blockers. Again, women were less likely to receive beta blocker and ACE inhibitor in the STEMI and non-STEMI cohort. Now, statin, more than 87% both gender received statin, but women in the STEMI cohort again were less likely to receive statin compared to men. Now, on the contrary, use of ARB, diuretics, calcium channel blocker, OHA, and insulin was significantly higher across ACS cohort. This could be explained by the fact that the women in our cohort were significantly older and were also sicker with more comorbidities on presentation. Now, in terms of treatment of STEMI, more than 76% of both gender received some form of reperfusion, either by fibrinolysis or primary PCI, although more received fibrinolysis than PCI. And more women did not receive any form of reperfusion therapy, and lower proportion received primary PCI or fibrinolysis. If you look at door to needle as well as door to balloon time, you can see that women too had significantly longer median door to needle time and door to balloon time. So in conclusion from this treatment of STEMI, we can see that women were more likely to be treated conservatively with lower rates of primary PCI or no reperfusion therapy. And again, these findings were similar to studies on ACS management performed in other countries. Now, if we look at, in general, women were less likely to receive angiography and PCI. Now, in terms of bleeding complications, overall, the rates of major bleeding in our cohort were low and reported a bleeding rate of 0.17 to 1% among all ACS groups and both sexes. However, women in the STEMI cohort significantly had more major bleeding compared to men. They too have higher in-hospital mortality and 30-day mortality, as well as 1-year mortality in both STEMI and non-STEMI cohort. So in conclusion from this slide, we see that women were less likely to undergo angiography and PCI. There's more major bleeding complications in the STEMI cohort, and women had longer CCU and hospital stay in both STEMI and non-STEMI cohort. And for unadjusted in-hospital and 30-day mortality, women had higher mortality in both STEMI and non-STEMI cohort. How about in-hospital mortality by age group? If you look at this chart, you can see that mortality increases with age, and women consistently have higher mortality in all age groups below 70 years old, while above 70 years old, mortality were higher in men. But overall, women still had higher in-hospital mortality rates than men. Now, if you look at this logistic regression analysis, taking into consideration of adjusting for gender as well as covariates with clinical presentations, you can see that after adjusting for clinic class, admission heart rate, and admission systolic BP, as well as comorbidities of diabetes and so on, in-hospital mortality and 30-day mortality was not significant anymore between men and women. However, at 1 year mortality, even after adjustment of covariates, the mortality remained higher in women compared to men. So this brings us back to the original graph that I shared earlier on about addressing the presentation and also outcome in women. We know that women has other non-traditional risk factors that perhaps we have to overlook over the years. And perhaps in terms of targeting and treating comorbidities, we do not have gender-specific guidelines as mentioned earlier on. And atypical symptoms of ACS in women too tend to throw a curveball at us and continue to pose as a challenge in terms of getting the right diagnosis. And we know women too have worse short and long-term outcomes following ACS. And there's also higher risk of excess complications as well as bleeding complications. So there is a significant gender treatment gap here, and we continue to face with this in terms with evidence of increasing mortality in women. So how do we then address these problems? Now, we know that primary prevention is pivotal in changing CV risk in our women. So early detection should really be done in addressing risk factors and also changing awareness of cardiovascular disease in women. And as mentioned earlier on, our current guidelines are not gender specific, and perhaps there's an underestimation of CV risk in our women, especially when non-traditional risk factors are not taken into consideration and may be difficult or usually under-evaluated. Also, making healthcare accessible to both gender. I think this depends, this would vary region to region as well as from countries to countries in terms of accessibility of healthcare. In Malaysia, PCI capable centers remain scarce and we're limited by our human resources as well as infrastructure. So in improving accessibility of healthcare, this should be able to help us improve our outcomes of ACS in women and also improving mortality in ACS in younger women. Again, another gap to address would be educating ourselves and our physicians in delivering optimal guideline-directed medical therapy equally to men and women. As from registry, we can see that women are less likely to receive evidence-based medicine or evidence-based therapies. So this is also a gap that we should be addressing in bridging the treatment gaps. Finally, last but not least, inclusion of more women in clinical research and trials to help us understand the differences between the gender and improving outcome in our ACS among women. Thank you.
Thank you very much, Dr. Lim. It's a great presentation, and especially on acute coronary syndrome, I think you have addressed what a lot of the other experts have highlighted, the disparity between men and women in all aspects of cardiovascular disease, and you've mentioned a few ways of how to address this. Now, thank you for sharing also the ACS registry in Malaysia. I'm just wondering, do you have any data on Minoka? Because like in women, there's non-obstructive, a predominance of non-obstructive coronary artery disease, like spasm, etc. So I don't know if, I know this registry goes back a while, but I don't know if you have any data looking at this. Thank you.
Thank you for the question. You're quite right about Minoka. So the Minoka is on the rise. It's probably underdiagnosed because we don't have a lot of data about it apart from Virgo and a few other studies. In Malaysia itself, our registry currently, we've not designed it to look at Minoka per se, but certainly it's something that our Women Heart Health Organization will probably take upon to then look into more details in terms of our registry. And looking into a breakdown of how well these women do and how should we tackle and target treatment for this group of women.
Yeah, okay, thank you.
Can I ask a question?
Yeah, sure.
In your registry, Dr. Lim,
Yes.
Amongst the 20% of the women who underwent had acute coronary syndrome, what was the proportion of the women in younger age? You said these women were more than the 50 years of age, younger population.
That's right. So I don't actually have the statistics or the breakdown of the age group, but in general, they were across the spectrum between less than 40 to 70 years old.
Okay.
The median age of these women across the cohort was of 64 to 65.
Because there is growing data collection about the younger women having acute myocardial infarction, acute coronary syndrome, and having high mortality than the elderly. You see, so I wanted to know about the younger population of the women who are having the incidence among these 20% of the women population who had acute myocardial infarction. Thank you.
Yeah, thank you. Unfortunately, I don't have that data at hand with me, but as I said, the median age for our cohort were between 64 to 65.
Oh, thank you.
Okay, great. Thanks again, Dr. Lim, for your presentation. And I think it's now time to move on to the fourth speaker. The fourth talk will be given by Dr. Renee Nakanishi from Japan, who's an assistant professor at the Department of Cardiovascular Medicine, Toho University Graduate School of Medicine from Tokyo, Japan. Okay, please, Dr. Nakanishi. Thank you.
Hi, thank you very much for the introduction. I'm Rine Nakanishi from Toho University in Japan. I'm honored to have the presentation today. I do not have any disclosure. So Dr. Lim elegantly summarized the sex differences and the coronary artery syndrome between men and women. So I will talk about the differences in a chronic coronary syndrome between the women and men based on the presentation, diagnosis, and risk and treatment. So Dr. Lim also showed that the women have the atypical chest pain in the ACS patient. So similar to the ACS patients, the women were more likely to have the atypical symptoms in men. So this is the data from the ischemia trial. So the woman was independently associated with a greater angina frequency. So while the woman had a more frequent angina, it's interestingly, the woman had a less extensive coronary artery disease and less severe ischemic than men. So meaning that there may be inherent sex differences in the complex relationship between the angina, ischemia, and atherosclerosis, which may have an implication for testing and treatment of patients with suspected coronary artery disease. So we also clinically experienced that women were more likely to present non-specific and unique chest pain than men. So this is a sub-study from the PROMISE trial. So PROMISE trial is well-known randomized trial that examines the clinical utility of the coronary CT compared to the functional testing. So this study showed that both men and women had a similar prevalence of chest pain, around 72%, but the symptom presentation differed between the men and women. So women were more likely to present their symptoms as crashing, pressure, or squeezing, or tightness, but the men were more likely to have a fatigue or weakness. So interestingly, similar to the ischemia trial, although men were more likely to have a non-angina chest pain, the men had more ischemia on the stress test and severe coronary artery disease on the coronary CT compared to women. So importantly, even though 70% of patients presented any chest pain in this study, so positive test results were only 50% in men and 10% in women. So meaning that this study also showed that sex differences in the complex relationship between the angina, ischemia, and atherosclerosis. So therefore, the recent ACC and AHA guidelines on the evaluation and the diagnosis of a chest pain warn that physician assessment often misclassifies the chest pain among the women and may underestimate the woman's risk. So we cannot exclude the potential cardiac events causes for the woman who present with a chest pain. So what is the diagnosis? So we are facing the issue about the low prevalence of coronary artery disease among the symptomatic patients. So over the past decade, so among the patients undergoing the diagnostic evaluation, so the prevalence of obstructive disease and ischemia is very low at about 10%. So further, current examination patterns show the high normal rate of coronary angiography, generally around 50 to 60%. So we have to be careful that appropriate diagnostic tests should be selected to identify a patient with suspected coronary artery disease. So in light of this problem of the low prevalence of coronary artery disease, so the ESC guidelines for the chronic coronary syndrome have recently been updated. So in this guideline, the pretest probability of obstructive coronary disease was downgraded based on recent studies. So presentation of this new pretest probability is expected to significantly reduce the need for non-invasive and invasive testing among the patients with suspected coronary disease. So in addition to pretest probability, a clinical likelihood of coronary artery disease is also recommended to identify the patient with obstructive disease. So non-invasive tests such as the exercise EKG or coronary CT and risk factors can be used in the clinical likelihood of coronary artery disease. So coronary CT is used clinically over the last 15 years, and CT is able to provide high diagnostic accuracy and evaluation of the presence, severity, and extent of CAD. And recently, we also can evaluate the functional CAD and provide the low radiation dose. So therefore, the recent international guidelines on the chronic coronary syndromes and chest pain recommend the use of coronary CT as a first-line test for coronary artery disease evaluation and have upgraded it to the class 1 indication. So there are two interesting studies presented recently. So in addition to these guidelines, this is a precise trial. So this was presented at the American Heart Association last week. So precise trial is designed to compare the usual approach of diagnostic patients with stable chest pain using a stress test and or invasive coronary angiography to a new precision evaluation strategy using a risk-based testing and coronary CT. So this study showed that precision care strategy provided 70% MACE risk reduction at 1 year compared to the usual testing. So similar findings are reported from the discharge trial. So this study was presented at the ESC meeting this summer and published New England Journal. So this trial compared to the coronary CT to the invasive coronary angiography among 3,500 patients with intermediate pretest probability with obstructive coronary artery disease. So this trial showed that coronary CT was associated with a 40% reduction in the MACE risk compared to the invasive coronary angiography, and almost 70% reduction in major procedural complications. So they also assessed the comprehensive effectiveness of coronary CT and invasive coronary angiography in women and men with a stable chest pain. So this study found no evidence for a difference between a woman and man and the benefit of using a coronary CT rather than invasive coronary angiography as an initial diagnostic test. And an initial CT scan was associated with fewer major procedure-related complications in women and lower frequency of the expanded MACE composite in men. So meaning that CT is a safe and effective diagnostic tool in women. But women sometimes hesitate to perform a coronary CT for women because of the use of contrast or radiation dose. So how about using a coronary calcium scan? So calcium score can be used for typically asymptomatic patients. But in this sub-study of PROMISE trial, they compare the prognostic utility of calcium scans with functional tests among symptomatic patients. So in this study, most events occur among patients with any coronary calcium, which is much higher than positive functional tests, between the 83% versus around 30 to 40%. So among symptomatic patients with any without calcium score is a very low risk cohort, and this patient may not require the additional diagnostic test. So calcium scores may be a good modality as an initial test to identify the high risk patients. So the Crescent trial used this diagnostic scheme to symptomatic patients. So from the Crescent trial, 350 symptomatic patients were randomized to calcium scans versus exercise EKG. And the only patient with any calcium or high pretest risk patients underwent the coronary CT. And here's the results. So at 1 year, cardiac CT reduced downstream testing by 50% compared to the functional testing. And calcium scans arm was associated with the reduction in cardiovascular disease events when compared with those with underwent exercise alone. So meaning that this study showed that the coronary CT can avoid false positive of other imaging studies if included earlier in assessment of ischemic symptoms. So what is the result by gender? So Crescent trial further investigated the sex differences in the performance of coronary CT with a functional test. As you can see, this sub-study showed that in women, cardiac CT has reduced downstream testing from 57% to 16% compared to the functional testing. However, in men, cardiac CT has only reduced downstream testing from 41% to 27% compared to the functional testing. So cardiac CT is more efficient in women than in men in terms of the downstream testing. So it should be noted that the risk factors for coronary artery disease differ between men and women. And first presented elegantly summarized the sex differences in the risk factors. So I don't talk much about this one, but there are sex differences, specific factors that are unique to women, which further increase the risk of cardiac events. So I will show the one case example. So this is a 34-year-old Japanese woman presented at a different hospital with chest pain and dyspnea for the past few months. So the doctor ordered the treadmill test, but EKG showed that ST depression in almost all leads. And after treadmill test, she was referred to our hospital because of cardiogenic shock. So when she arrived at the hospital, her condition and vitals are stable. But she was at basically low pretest probability of obstructive coronary disease due to her age, but the clinical likelihood of a coronary artery disease is high because of EKG change and clinical presentation. So we performed the coronary CT. And you can see that the coronary CT showed that thickening of the aortic wall and severe stenosis in the left main. So we diagnosed this patient as Takayama's disease and send the patient to the bypass surgery. So Takayama's disease is not a common disease, but coronary CT can be performed for such patients, even young patients, but having a typical angina and EKG change. As shown earlier, the prevalence of obstructive coronary artery disease is recently low, around 10% in women. But we have confirmed that many patients have non-obstructive atherosclerosis on the coronary CT. And it's recognized that despite having a low prevalence and volume of coronary atherosclerosis, the women are likely to have a greater symptom burden and a high rate of functional disability and adverse events. So this meta-analysis was reported from the Society of Coronary CT. So on the CT, the cardiovascular aneurysm risk is only 0.2% in the absence of a plaque, but the risk increased to the 1.6% when plaque is built, even in non-obstructive cases. So we primarily focus on the stenosis severity and high-risk plaque on the coronary CT for the assessment of coronary artery disease, which is a lesion-based assessment. But coronary CT allows whole heart imaging and assess the entire coronary atherosclerosis. So more recently, quantitative plaque assessment of characteristic and volume based on atherosclerosis of the entire coronary artery is considered more important for estimating risk in patients with chronic coronary syndrome. So I will show the two studies. So this is an ICONIC study. So ICONIC study was an international multi-center study that compared the ACS and non-ACS patient and examined the prognostic value of quantitative plaque imaging of coronary CT. So in this study, the necrotic core and fibrotic plaque, which are the darker plaque on the CT, and their overall volume increase in ACS patients than non-ACS patients. So similarly, a Scott Hart study showed that the patient with more than 4% of a low attenuation plaques, which is also the darker plaque on the CT, develop the myocardial infarction over time compared to the patient with less low attenuation plaques. So these two landmark trials show that the similar result, that the high volume of darker plaque on the CT was associated with a further cardiovascular risk. So how about the results by gender? So this Scott Hart trial further examines the sex-specific coronary CT plaque characterization and the risk of myocardial infarction. So in the sub-study, so among the patients with a stable chest pain, so similarly, low attenuation plaque is a powerful predictor in women and men with a low attenuation plaque greater than 4% associated with 6-fold increase in the risk of MI. So this study showed that quantitative plaque analysis is a robust predictor of cardiac events regardless of sex. And so current cardiovascular CT society guidelines strongly recommended the management of patients with a non-obstructive coronary artery disease with preventive medications such as aspirin, statin, or other lipid medications. And the other recent topic include the INOCA. So it has been reported that approximately 20 to 30% of patients with non-obstructive coronary artery disease have the ischemia. So patients who experience the INOCA may benefit from a variation of the functional significance of intermediate coronary artery stenosis. So both invasive or the non-invasive functional assessment is recommended for a patient with a suspected INOCA. This is a sub-study of ischemia trial. So among the patients enrolled in the ischemia trial, but confirmed that the who are not, no, this is a sub-study of the ischemia trial. So the risk of INOCA was younger and female and fewer coronary artery disease risk factors. And the prevalence of INOCA was 13%. And INOCA showed a 4.2-fold higher in women compared to men. So how about the management of INOCA? So unfortunately, there are studies on the therapy to improve the coronary microvascular dysfunction currently small, and there is no evidence based on the treatment of coronary microvascular dysfunction. So lifestyle modification and risk factor management are basically recommended. So this is a summary. So women and men differ substantially in their clinical presentations. So women commonly presented with chest pain symptoms similar to men, but also had a greater prevalence of other symptoms. So it should be noted that the risk may be underestimated when women presenting with a chest pain. And cardiac CT is more efficient in women than in men in terms of the time to reach the final diagnosis and downstream testing. And coronary CT may be a good modality as an initial diagnostic test to estimate the risk among the women patients with chronic coronary syndrome. So further research on the gender differences in the chronic coronary syndrome is needed to recognize the best diagnostic tests and treatment specific to women. Thank you very much for the attention.
Okay, thank you very much, Dr. Nakanishi. Thank you for this very good overview on chronic coronary artery disease in women. I think it's great that you highlighted the importance of coronary CT, coronary artery calcium score also in the evaluation. So we have a variety of tools to help us evaluate women with chest pain. I'm just wondering, in reality, in your clinic, if you see a patient with chest pain, how do you go about managing or sort of arranging the tests?
Thank you very much. So, so the guideline recommends is that we can use the coronary CT or the functional test, but I think the coronary CT is good because of the evidence that I showed today. That very easy test and a very low radiation dose, and we can see the atherosclerosis, even the obstructive or non-obstructive. And also, I showed that the prevalence of coronary artery disease is only 10% in women. So very low likelihood of coronary artery disease. So we can do the functional test for the such low the prevalence of the obstructive coronary artery disease. So I think the coronary CT is the best modality to do the evaluate the patient with a woman as an initial.
Okay, because I think these up to even now, very often if a woman has a positive initial test, she goes for a coronary angio, and then if it's negative or there's insignificant stenosis, she's labeled as, you don't have any problems, but we know that you can't see positive remodeling on a cardiac cath. And so there's certainly, and if you don't go ahead and do these functional testing, then you're probably going to miss out on spasm, etc. So yes, I think it's great that you've highlighted the role of coronary calcium score and also coronary artery CT. Okay. I don't know if any of the other participants or anyone on the panel have any other questions.
What about the role of fibers in non-obstructive coronary arteries?
Excuse me,
yeah.
Sorry.
The role of IVUS.
Oh, IVUS. Oh, thank you very much. Yeah, IVUS is a good modality to see the plaque, but it's also the invasive. So it's hard to do typically my patients, women patients, don't want to do the cath. So I think it's still coronary CT is good to see the plaque. So And there are many studies comparing between the coronary CT and the IVUS, and the coronary CT is a good modality to do to see the plaque atherosclerosis.
Okay. So if the patient does go for a coronary angio and it looks normal initially, then maybe they should go ahead and get an IVUS if they haven't previously had CT done. Right. Okay. Great. Well, thank you very much. I think we'll close this session and then move on to the 5th talk. Okay. Very pleased to introduce Dr. Zhijie You from Taiwan. She's an assistant professor at the College of Medicine, National Taiwan University, Division of Cardiology and Department of Internal Medicine at the National Taiwan University Hospital in Taipei, Taiwan. And the topic of the talk is sex differences in drug and device therapy of heart failure, looking at HFrEF versus HFpEF. Okay, invite Dr. You.
Thanks, Professor Young, for the kind introduction. It's truly my honor to be here. My assigned task is the sex differences in drug and device therapy. I'll divide my speech into 3 sections: drugs, ICD, and CRT. As the previous speakers had mentioned many times, the female in the clinical trials is usually under-enrolled, and therefore the small number limits the statistical power to analyze sex-specific issues. However, current guidelines are largely based on data reflecting responsive therapies in men. So when we see a female patient in the clinic, we are treating the patient based on the guidelines that are good for men. So I think I cannot stress more that we need sex-specific guidelines in the future. Okay, so I will begin with the drug therapies. For this table, you can see that it covers the ACI, ARB, and ARNI. It organized most of the landmark trials. As you can see here, that female composed of only 20 to 30% of the study groups. And if you look at the right-hand side, the sex-specific outcome, if the female patient is larger, then we can see significant benefits in females similar to males. From the third one, you can see a small clue that female actually benefits from ACEI with lower dose, while men need higher dose of ACEI. And similar findings are seen in ARB that, again, with more case number, you can see female benefits from ARB like men. But in the third trial, you can see that the female actually benefits from ARB with lower dose. I'll talk about that more later. ARNI is the latest drug that used in heart failure treatment, and the data is very positive. In ARNI actually had another very interesting study called Paragon. Paragon in heart failure enrolled patients with ejection fraction below 40, which is HFrEF patients. And Paragon enrolled patients with ejection fraction above 45, which is called like HFpEF patient. When these 2 data are combined together, you can see the figure on the right-hand side. The blue line represents men, and the red line represents women. If we draw a line from here, 50% of ejection fraction on the right-hand side represents the HFpEF patient. And you can see that the blue line and red line, they are parallel to each other, and the gap persists with the ejection fraction. And if you look at the rate ratio at 1.0, you can see that women actually benefit from the ARNI up to above 65%, of ejection fraction, while men benefit from it below around 55%. So this implies that female benefits from heart failure medication, even with higher ejection fraction compared to men. This table covers beta blocker, MRA, and SGLT2 inhibitor. Again, you can see here the female composed of a small part of the study group, around 20% to 30%. For beta blocker, it looks like female and male benefits similarly in the study. And for MRA, the benefits is similar in the study. However, for spironolactone, we know that it has another study focusing on HFpEF population. Though TopCat is like a neutral study that patients with this drug and without this drug have similar CV death. But if we look carefully into the secondary endpoint, you can see that for all-cause mortality, the women have actually significant benefits from this drug, while men did not. So again, this finding is very similar to ARNI, that women with higher ejection fraction can benefit from heart failure medication, while men may not do. SGLT2 is another very new drug. Luckily, you can see here, let's see this slide. Both dopagliflozin and EMPA, both in HFrEF, we can see very similar benefits in men and women, though in this study, female has non-significant benefits. But in HFpEF study conducted with these two drugs, we can see very consistent finding between female and male, male and female, that both sexes benefits from these drugs. For the rest of the heart failure drugs, if we look at this, funny current inhibitor, ivabradine, again, we can see very similar benefits between sexes. Let's take a deeper look about the DITCH study, which is the digoxin actually increased the death rate in the study population. If we look into the sex difference, as you can see here, death from any cause, death from CV cause, or death from worsening heart failure, actually only women have worse outcome in this study, while men actually benefit from death from worsening heart failure. So here it's clear that men and women have very different presentation in terms of response to medications. So why is men and women so different? There are many aspects. I believe the previous speakers had mentioned a lot. I will just quickly summarize them. First of all, from epidemiological study, the risk factors between men and women are so different. Women has less physical activity and higher chance of obesity, and women experience pregnancy. Therefore, the pregnancy-related gestational diabetes and preeclampsia will increase the future chance of diabetes and hypertension. Women also have this peripartum cardiomyopathy, which definitely will increase the risk of heart failure. Women are more sensitive to environmental or emotional stress, therefore increase the chance of stress cardiomyopathy. Women have definitely more autoimmune disease, which is related to cardiac diastolic function. Also, with regular menstruation, women have more chance to have iron deficiency. In other than anemia, the iron deficiency can affect our immune system and also the cell metabolism. Also, women have more breast cancer, and the chemotherapy related to it may have damaged our heart. In addition to different risk factors between men and women, the physiology is also very different. From the gene point of view, women have different expression of gene. Also, women have smaller anthropometry with a lower body weight, lower body height. With estrogen, the women have different fat distribution, different hepatic metabolism or renal clearance. Women have higher inflammation, and therefore they have different aging process. Altogether combined, the women would have altered myocardial structure and altered cardiac metabolism and vascular dysfunction. And altogether, women are predisposed to have HFpEF condition. Even in patients with HFpEF, women had different remodeling compared to men. As you can see here, the women have more structural change, more concentric remodeling, more concentric hypertrophy. And this, the concentric and eccentric hypertrophy, the difference is shown on the right-hand side. And we observe with the different presentation, we also see the different response on concentric and eccentric remodeling. We can see the right-hand side that in eccentric remodeling, higher dose of ACEI actually have better response compared to lower dose of ACEI. So earlier we always say, oh, you have to titrate up the dose to the target dose. But if you look on the left-hand side with concentric remodeling, you can see that with higher dose, there is actually less benefit compared to lower dose in concentric remodeling. This may explain that from previous slides in the studies of ARB and ACEI, that women may benefit from lower dose of these drugs. Okay, the second part is about the ICD. Again, you can see here all the landmark trials, women composed of only 10 to 30%. And on the right-hand side, you can see that the benefits of mortality actually all lie on males. Females actually doesn't get the benefits. If you look at the hazard ratio in these studies, they are actually very heterogeneous. But of course, if you also look at the confidence interval, the range is very high. So this lack of benefits may be from not enough number of cases, or worse, it may want to say that the female really didn't benefit from ICD. If we dig deeper into these studies, we can see that women actually have lower rate of appropriate ICD intervention in those patients who had received ICD implantation, and the ratio is 0.63. Women have less chance to get appropriate therapy in ICD from ICD. And furthermore, women not only has less benefit, they experience greater complications than men. In major complications, the lead replacement and pulmonary edema has higher chance. And also for minor complications, women experience more than men. And these complications not only in the early events, but also extended to follow-up period. So including lid dislodgement or not including lid dislodgement. So in this slide, we can see that women, we actually don't have very solid evidence that for women with heart failure, for primary prevention, women did not really benefit from ICD. Of course, for secondary prevention, I believe the next speaker will address more. So for CRT, again, women composed of 20 to 30% of the patient. And you can see on the right-hand side, the outcome. Actually, the female, even with a smaller population, the women showed greater benefit than men. However, with the greater benefit, women has less chance to receive CRT compared to men. And this gap lasted from earlier to recent. The gap is still there. If we look closer to the QRS width, if the QRS is above 150, it's very clear that both women and men benefit from CRT. However, if the QRS width is narrower, like 130 to 150, the women actually benefit while men did not. So this tells us that women can benefit from CRT more than men. So this draws the conclusion that the drug therapy in HFrEF is actually similar between men and women. However, ACEI and ARB, we can use lower dose in women. Women benefit from heart failure medication with higher ejection fraction, including those patients with HFpEF. The benefits of ICD in women with heart failure for primary prevention needs further clarification. And the CRT benefits both men and women, but women benefit more with narrow QRS duration. Thank you for your attention.
Great. Thank you very much, Dr. Yeo, for your very comprehensive presentation. And I think it's really quite striking that we all know what guideline medical therapy for heart failure is, but there are obvious, as you pointed out, differences in response in men and female to the treatment, and yet again we don't have very good recommendations. Now I'd just like to maybe my thoughts on the ICD. Like you said, there's not enough women in the trials, so the poor response may be due to that. But I think another point is maybe women with cardiomyopathy have less ischemic cardiomyopathy than men. So maybe the scar burden in women is probably less so than in men. So I don't know, maybe that might affect the ICD appropriate firing. Yeah, so that's just a few comments. Now, I don't know if any other participants have any questions.
Recently improved study shows that the impact of ICD is same for the men and women, but the related complications are more in women, you see. That might be the reason that it is controversial in women. I think so.
Mm-hmm.
Complication related with the ICD, as such our speaker mentioned.
Yes, that's right. She mentioned that ICD complications are more in women. Yeah. Maybe that has also to do with, I think, women.
Firing.
We anatomically we're smaller. I don't know if that's anything in terms of when you're actually implanting the device, and yeah. Okay. All right. Okay. Well, thank you very much, Dr. Yeo. I think we'll move on to our last but not least speaker. Okay.
or a question,
Fine.
please.
It's my pleasure to introduce Dr. Warankana Bunyapist from Thailand. She's an associate professor at the Division of Cardiology, Department of Medicine in Sri Raj Hospital Faculty of Medicine in Mahidol University, Bangkok, Thailand. Now, the topic of her talk is sex differences in drug and device therapy in cardiac arrhythmias, looking at structural heart disease versus inherited arrhythmia disorders. Okay, thank you very much.
Thank you, Dr. Yang, for introduction, and it's my pleasure to join today our webinar. And my topic today is sex difference in drug and device therapy in cardiac arrhythmias, which focus on structural heart disease and inherited arrhythmia disorders. Sex difference have the potential to impact diagnostic and therapeutic interventions in a wide variety of medical conditions, and cardiac arrhythmias are no exception. And there are many sex differences in normal cardiac electrophysiological variables include women have faster baseline heart rate than men and shorter refractory period and all interval in the ECG except the QT interval. For the QT interval, we all know that women have longer QT interval than men, and corrected QT interval by Besset's formula overestimates this difference because of the faster resting heart rate in women. And in women, data suggests that there's gradual increase of QT interval with advancing age, while in men, there is a post-pubertal dip, which may or likely caused by the effects of the sex hormone. And first arrhythmia that I'm going to talk is bradyarrhythmia and pacemakers. And for pacemaker implantation, indication is different. Women are more likely to have sick sinus syndrome as an indication, while men have more AV block as an indication of pacemaker therapy. And pacemaker implantation rates in women have been consistently lower than men across multiple large national registry. On left-hand side is data from US registry, and on the right side is from Swedish registry. But the implantation rate of like high voltage device like ICD and CRT, are more different, like as Dr. Yu tell you. And pacemaker implantation rates in for the type of the pacemaker. Women have receive more single chamber pacemaker than men for both indication of AV block and sick sinus syndrome. And for the complication, or as our chairman discussed before, some studies shown higher rate of complications in women at the time of implantation. The difference is driven by higher incidence of pocket hematoma and pneumothorax, and it's made because of smaller body habitats in women. And for the long-term clinical outcome after pacemaker implantation in quality of life, there is similar rate of major adverse outcome and all-cause mortality after pacemaker implantation between women and men. And female sex is a predictor of lead extraction-related major complication and clinical failure in large European registry. And second arrhythmia that I'm gonna cover today is atrial fibrillation. The age-adjusted incidence and prevalence of AF are lower in women compared to men, and women with AF tend to be older and have more comorbidities such as hypertension, valvular heart disease, heart failure with preserved ejection fraction. And women also has worse AF-related symptoms when compared with men. And female sex, as in Cardiovascular score, is a stroke risk modifier, which increases the risk of stroke in patients with additional non-sex-related risk factors for stroke. And women also experience more severe ischemic stroke with AF and have worse long-term outcome following a stroke. And the age-adjusted mortality for women was consistently higher compared with men. This data from study investigating the global burden of AF from 1990 to 2010. And it was attributed to higher mortality among women diagnosed with AF in low and middle income countries, while in developed countries, the mortality is higher in men. Data from National US Registry from 2010 to 2014 show that women were 9 to 33% less likely than men to receive OACs at all levels of Cardiovascular scores. However, after utilization of NOACs, the difference is lower. And more recent studies show no sex difference in rates of OAC use for stroke prophylaxis. And for the treatment with VKA, show higher residual on treatment stroke risk and lower TTR in females, but no difference in major bleeding when compared to men. Treatment with NOACs show more or equally effective in females and males, but lower major bleeding rates in females compared with males. In Aristotle, Everose, Rely, and Rocket AF trials reported significant lower NOAC-related bleeding risk in females compared with males. And for medication for rhythm control in AF, female sex is associated with significantly increased risk of Torsades de Pointes with the use of antiarrhythmic class 3 and class 1A. And for the catheter ablation of AF, women with AF are less likely to be referred for catheter ablation than men. This data is from national US cohort of over 100,000 patients who underwent AF ablation from 2000 to 2012, which showed that women had lower rates of AF ablation in an odds ratio of 0.83. And for the outcome of AF ablation, female sex was associated with higher long-term recurrent rates after catheter ablation of AF. And this data from Kansai registry show more recurrence rate in women. And the reason may be from significant older age of women who underwent AF ablation and more non-pulmonary vein-mediated atrial fibrillation. And for the complication rate, female sex is associated with higher incidence of complications with catheter ablation, especially groin hematoma and vascular complication. How to improve the care in AF women? I think we have to create more referral pathways to ensure earlier referrals for AF ablation in women, and to conduct more studies about the location of main substrate for AF in women, and to develop the AF ablation technique that has more effective and less complication, especially in women. Next topic is ventricular arrhythmia in structural heart disease. For the treatment of ventricular arrhythmia in structural heart disease, VT ablation, female patients were very underrepresented in VT ablation trial. Women were enrolled in just 6 to 13% of all patients. And data show that catheter ablation of ischemic VT in women may be associated with slightly higher VT recurrence rate, but not in non-ischemic cardiomyopathy and ARVC. And Women are also underrepresented in ICD trial, which none of these trials were powered to determine a sex-specific outcome. But in AVID study, which is a secondary prevention ICD trial, ICD therapy was associated with improved survival regardless of sex. But women were younger and had more non-ischemic cardiomyopathy and VF rather than VT as the index arrhythmia. And this is the meta-analysis of ICD primary prevention trial, show no difference in overall mortality between men and women who receive ICD, but women experience less appropriate ICD intervention. And women did not reach statistical significance for benefit of ICD on mortality, while men has reached statistical significance on ICD survival benefit. And again, from our large US CID database, which include more than 85,000 ICD, show the proportion of female patients implanted ICD was just 26%. But mortality rate were similar between women versus men who are receiving ICD. And similar to ICD, women are also underutilized in CRT implantation. That may explain why fewer women than men have indication for CRT, since women more often to have heart failure, mid-range or preserved EF. But after implantation, female patients implanted with CRT device are associated with significant more improved survival compared with male CRT patients. For the complication rates, female ICD and CRT recipients have a higher acute complication after CIED implant compared with male. Last topic is our inherited arrhythmia disorders. And I will cover two diseases that have marked sex difference in prevalence. First is long QT syndrome. There is some female preponderance of inherited long QT syndrome, which explained from genetic transmission distortion to female and hormonal effects on defect ion channels. As in general population, women with long QT syndrome, especially in long QT1 and long QT2, have on average longer QT intervals than male patients. The most prominent sex difference is in long QT2. And the risk of arrhythmia of long QT2 increased significantly in the postpartum period. In long QT2, the risk of arrhythmia remains higher also after menopause, while in long QT1, after menopause, the risk of arrhythmia is lower. And for the long QT3, there are conflicting reports on sex difference in ventricular arrhythmia. Both indicated higher risk of long QT3 men, or indicating no additional risk in long QT3 according to sex. But beta blocker therapy efficacy may be greater in women with long QT3 compared with men. And for the drug-induced QT prolongation, drug-induced QT prolongation is more pronounced in women. The risk for drug-induced arrhythmia is higher at the time of menstruation and during the follicular phase, when the estrogen level is high. And the last disease is Brugada syndrome. Clinical manifestations of Brugada syndrome are eightfold more frequent in adult men than in adult women. The genetics of Brugada syndrome have not been shown to be a factor in sex difference, but Brugada syndrome is genetically diagnosed in just 20 to 25% of clinical cases, and it has been suggested that androgens may affect the ITO channel and aggravate ion channel dysfunction. And there are reports of regression of Brugada ECG in sterilized men. In summary, there are clear sex difference in epidemiology, presentation, clinical course, and cardiovascular care of cardiac arrhythmia. Acknowledging sex difference in guideline documents and advocating for sex-specific recommendations when applicable, taking steps to ensure adequate female representation in clinical trials, and promoting research to understand the mechanism that underlie these differences are important steps that can be taken to diminish the disparity observed in clinical care. Thank you.
Great, thank you very much. Does anyone have any questions regarding this topic on arrhythmias? Okay. You mentioned that women have longer QTs, and so has it been found to be with medication that can prolong the QT interval, there is more risk of arrhythmias happening?
Yes, or in the medication that prolong QT interval, there is a risk more in women to have Torsades-de-Pointes polymorphic VT with the medication than in men. Mm-hmm.
But I don't think we really see any advice specifically about women taking this medication, right? Yeah.
Right.
Okay. I think there's some participants who had wanted to ask some questions or make some comments, but were muted. Is there anyone that wants to ask any questions to any of our speakers? Okay. Now,
may I have a question?
Yes, sure.
Thank you. So for the NOAC, I'm just curious that since women have smaller body size compared to men, but the dose of NOAC is universal, how come the outcome is there's no difference between men and women? What's your perspective?
Yes, that's interesting questions. Or in VKA, there is no difference in major bleeding between men and women, but in NOACs or the data that comes out, it comes out that maybe in women have less bleeding than men. But for the dosage, I think in women, some of medications have lower dosage from like the body weight of the woman. So it's maybe affect less or bleeding than in women. Yeah, that's, I think.
Thank you.
Okay. Are there any more questions for any of the speakers? Okay, if not, I think because of time, I'm going to make some closing remarks. Now, first of all, I'd like to thank the APSC for organizing this, and in particular, to thank Professor Junhee Ling for organizing such a great program. I think this is a really important topic, and it's wonderful that we have a great, they were all female experts on this webinar, and I think everyone gained a lot of input from this. So we first of all heard from Dr. Uli Zakhan, who gave us an overview on sex-specific risk factors and highlighted the importance of hormone, pregnancy, complications, psychological aspects, and also chemotherapy as independent risk factors for coronary artery disease and cardiovascular disease. But again, I think with what everyone has highlighted is that there aren't enough trials represented by women, and there's a lack of sex-specific recommendations. So I think that was a recurring theme. Now, the second speaker, Dr. Kuratulan, gave an overview on how hypertension, obesity, and diabetes affects women differently. And the third speaker, Dr. Lim, went over acute coronary syndrome and highlighted how women present differently and how psychological stress plays a very important part. And she also presented the Malaysian registry, which was very interesting. And the fourth speaker, Dr. Nakashimi, went over chronic coronary syndrome and gave us an important message that calcium score calculation and coronary CT is a very good non-invasive modality to assessing women for coronary artery disease. And fifth speaker, Dr. Yo, looks over heart failure treatment, in particular HFrEF versus HFpEF. And it was seen that although we all have the same, we all receive the same medication, women actually respond differently. And in particular, the role of HFpEF in women in heart failure. And last but not least, Dr. Bernie Passett went over arrhythmias and going over congenital arrhythmias and also ICDs and CRTs. So I think on the whole, it's been a really great session. I think I myself have learned quite a lot, but I think what everyone has highlighted is that there's still really a lack of more information, particularly in women in heart disease. We've gone over that the guidelines tell us we should be careful for these risk enhancers, but we aren't given any specific recommendations on what to do, what kind of medication, what doses, and who to give them to. So I think we all need to, there's still a lot of work ahead of us. I think we need to educate ourselves, professions, and also the general public using maybe media, using the media, and also the clinical trials. We have to work harder to get more women into the trials. Now, I don't know if my co-chair has any more comments to make, or Professor Lim. Thank you. All right.
Please unmute your microphone. Your microphone is muted.
We heard about the sex-specific risk factors, which are the reason for increasing mortality in the women. But on the other hand, non-traditional risk factors, which usually, as was told by our fourth speaker in acute coronary syndrome, that there is delay in the therapeutic procedures in case of women, and the non-compliance of drugs, and the late referral of the women in the middle income countries or low socio-economical countries due to the unawareness of the and the less education in these countries in women. So we must concentrate on those issues also, not only due to these issues need to be tackled to overcome in each specific region of these Asian countries, considering the availability of the resources, local practice pattern, access to care, other factors including ethnicity, culture, psychosocial, educational, and socio-economical status might contribute to the sex differences in CVD in women. There is really urgent need to have more data in regions who are lacking, so that both patients and the physician and woman must consider. Depending upon their data, they must prepare the guidelines to treat the patients. Thank you so much.
I just needed to make a small comment. Am I allowed to do that?
Yes, sure, please.
Yeah, thank you. It was a wonderful session. This is Professor Nusrat from Islamabad. I just have a question or comment from my Japanese colleague, and I feel honored that I've also been trained in Japan after my training at Mayo. She mentioned that CT angiography would be the best diagnostic modality. I've been a little apprehensive because I think 4 years ago, there was a study from American College of Radiology saying that one CT angiography makes the radiation stay in your body for 4 years and 7 months. And since the pathophysiology of the disease is that it is the microvascular and it is the endothelial dysfunction, I still feel IVUS, although invasive, but it is, I would call it semi-invasive. I think that perhaps is the best to diagnose the disease and pick it up at earlier stages. And indiscriminate use of CT has given rise to increased number of all malignancies in women in our part of the world. I'm surprised to see many women with lung cancer. Ovarian, of course, is gender dependent. And so this was my apprehension. She said that they use small dose. So I wonder, what does she mean by small dose? Thank you so much.
Okay. Dr. Nakanishi, do you want to reply? Do you know the dose?
Yes, thank you very much. It's a great point. But so the for radiation dose, I think the radiation dose is really low at the coronary CT recently, because I can't give the less than 1 millisieverts for women if the heart rate is really control it's low. So I think the coronary CT is not so harmful for women because of the radiation, the low radiation dose. And then I don't remember for the next question, but
Oh no, I was just mentioning that IVUS, although I would consider it semi-invasive, because this still would be the gold standard to diagnose the disease, which is microcirculatory in origin. And since the acidoma does not protrude into the lumen, it causes ulceration along the wall. And if at all there is outward remodeling, negative remodeling of the blood vessel. So I was just wondering, so I think we need to discuss it further, and maybe someone from radiology can give us a definite reply. Thank you so much.
Yes, I think that's a very good point, because we aren't able to do any functional testing if you're just looking at the CT. And so, for example, if you're looking at coronary spasm, you wouldn't know, if you didn't do any ergonomic provocation testing, then that's probably going to be missed. So there are limitations to every different modality. So I think it just depends on what you have available and when you assess the overall risk and how the symptoms are.
Yeah, that's right. Thank you so much.
Thank you. Okay.
Yes, thank you.
Does Professor Lin want to give us any comments?
Oh, it's my pleasure to listen to the whole webinar. I really learned a lot. I don't have further comment. I must thanks for the two co-chairpersons, very intriguing in the leadership of this section. It's very interesting. I think it's really a good time to relook at the sex difference in cardiovascular diseases, and we have to pay more attention to that. Thank you for all the presenters. Very interesting presentation. Thank you.
Okay, that's great. Thank you to everyone. I think I've really enjoyed this whole session and I've learned a lot. And I hope that from now onwards, it seems to be there's a lot of work for us all to do. So I think hopefully we'll gain a bit more information with further work. And also I'd just like to shout out to Dr. Saltina Habib for posting a lot of really very encouraging comments in the chat room. To every speaker, she's made some really great comments. So thank you to our participants and also to Dr. Habib. Okay, so I think with this, we'll end this seminar, and thank you to everyone. Have a very nice rest of the day. Okay, bye-bye.
Thank you so much. All the best.
Thank you. Thank you.
Thank you.
Thank you.
Dr. Julian?
अम्मा बुड्ढा मूंदा हमारा एक वेबिनार हो रहा था तो 9:45 मैंने याद किया तो अभी बुड्ढा मूंदा 8 दिन और माशाल्लाह 2 घंटे